Welcome back, and please take your seats. Well done to all of you who've made it back after lunch, and I'm sure we'll fill the room up with the lineup that we're anticipating. I'm a cardiologist, and we're to take you through the second half of the cardiology program. Myself, Dr. Samia, will invite our two speakers to lead the next session. Our first speaker requires very little introduction. I was going to call him the grandfather of cardiology, but I think there's some older colleagues who'd want to be that fellow. But certainly his impact as a cardiologist, as a lecturer, and as a teacher in the region is of that grandfather status. Professor Elijah Ogola is going to talk us about how to improve outcomes in heart failure. So without further ado, welcome to Professor Ogola.
Thanks, Mohammed, for making me older than I feel. I thank the organizing committee for this conference for inviting me to participate in this. A lot of what I say, I'll talk about, I think, overlaps with what my two colleagues said in the morning. Unfortunately, I missed what they said, so I can only assume, because the organizers, in their wisdom, thought that I needed to be in a political motorcade or something like that. So I was given this topic by the organizing committee, and I've tried to interpret it in the way that I think would fit this audience, and I hope that satisfies the organizers. So I've already been introduced. I think most of you know me anyway. Really no disclosures. I've been in this space for a long time, so obviously I've interacted with a lot of the industry in this space, but none of them have any role in this presentation. This is what we'll sort of go through: introduction, spectrum of heart failure, and opportunities to improve outcomes, because that is really our role across those various subtopics. So this is just to remind ourselves the reason we are concerned about improving outcomes in heart failure is because heart failure carries a significant morbidity and mortality burden. And you can see here, compared with various cancers, our perception is cancer is the real killer, that heart failure really outperforms, if you like, many of the cancers. So it is a burden. The next slide is just to highlight the fact that, in fact, that burden is highest in low and middle income countries and Africa specifically. So on the right side is mortality data from the so-called TISA study, which many of you have heard about. It was a registry of heart failure admissions across several African countries. That is now more than a decade ago. And you can see those very high admission and mortality rates. On the left is a study that was called INTER-CHF. I think Felix Baraza was actually one of the participants in this study that looked at heart failure across several regions of the world. This was done under the auspices of Salim Yusuf. And what you can see there on the extreme left is the one-year mortality in Africa. And you can see that clearly the mortality in Africa is about, for example, 3 times the mortality in China. So we have a specific burden related to heart failure. Now, this slide is an adaptation of the classification of heart failure that was initially proposed by the Joint American College of Cardiology, American Heart Association guidelines of, I think, 2005 or 2007, when they brought the concept of stage A, stage B, stage C, stage D. Stage A being people who are at risk of heart failure. So if you are sitting here and you are a smoker, for example, you are in stage A heart failure, however normal you feel. And stage B being those with structural heart disease, but with no history, previous or current, of symptoms of heart failure, symptoms and or signs. Stage C is really the spectrum of clinical heart failure that we deal with on a daily basis as clinicians. And stage D, is advanced heart failure. So there is a group that did a publication, I think it was early 2021, following on the footsteps of the guys in coronary artery disease. We've all heard about the universal definition of myocardial infarction. So this was towards a universal definition of heart failure. And they adopted this and sort of renamed it. So there is at risk for heart failure, pre-heart failure, heart failure per se, and advanced heart failure. So I'm sort of going to address how we can improve outcomes in each of these stages, except the last stage. So obviously, primary, or in this case, primordial prevention, like Joel Watt said during the previous session, is better than anything. And we have very, very clearly defined risk factors that would end up in heart failure. And our job as healthcare workers, the problem with clinicians is sometimes we think that our responsibility is only to the patient that is in front of us. But we should adopt our role as healthcare leaders, not just as clinicians. So everything from recognition of heart failure, from making sure that our children don't get rheumatic fever and therefore rheumatic heart disease, and all those things are part of improving outcomes in heart failure. Then we have those that have got structural abnormalities, structural and or functional abnormalities. So for example, the diabetic who has got an elevated proBNP, the hypertensive who has got LVH, the kid who has had rheumatic fever and has got rheumatic carditis, has got valvular involvement but is not symptomatic yet. We know that prophylaxis with penicillin prevents progression to worsening of the valvular problem and therefore overt heart failure. So all these are stages in which we can intervene. So then most of the rest of that, I think 10 minutes or so I have, is going to be focused on stage C, which is, of course, our sort of comfort zone as clinicians. We tend to see those people who are panting for breath and can't lie flat and have got swollen legs, etc., etc. So I'll start with, this is, as you'll realize, the algorithm for diagnosis of heart failure from the latest iteration of the European Society of Cardiology guidelines in heart failure. And I'm picking two things here. This thing doesn't show, does it? I can't see it. Two particular things here because I think is important as one of the challenges and where we can work towards improvement. You see the centrality of two things in this algorithm. One is measurement of BNP or proBNP. So in other words, a biomarker of myocardial stress. And two is imaging. And the basic imaging is echocardiography. My daughter sitting there, Ukraine, is going to talk a little more about imaging, including advanced imaging. And why is this particularly important in our environment? I'll use this slide to highlight it. It's from one of the publications for a different reason. But the important thing is that the biomarker for myocardial stress is actually supposed to be a screening test because imaging requires equipment, requires expertise. These equipments are expensive, are not everywhere. So it's actually a cost-saving measure because your patient with cardiorespiratory symptoms suggestive of heart failure who has got a normal BNP or proBNP does not have heart failure and therefore does not need the imaging. The irony, and I don't know if the Roche guys are here, I see they have got some sponsored program tomorrow, and today, yeah, I hope they are listening to me. If they are not here, tell them. The irony is that you go to the developed world And doing a pro-BNP is that cheap, absolutely cheap, costs nothing. You come to the developed world, it costs you about $100. So these are some of the issues that we have to tackle. The next thing with respect to imaging is because we live in an environment where we still have a lot of structural heart disease. We have people who get into adulthood with uncorrected congenital heart disease. We have pericardial diseases. We have, of course, valvular heart disease from rheumatic heart disease. And we were just discussing there, I mean, the number of children, well, young adults I've seen who have got critical mitral stenosis, who are being killed by being given an ACE inhibitor, for example, that has got absolutely no role in that context. In fact, it's inimical to the benefit of the patient. So that's why imaging is important in general in the evaluation of your heart failure patient. But in our environment where we deal with a lot of structural heart disease, then assumes critical importance. So these are some of suggestions of things that we can do about improving diagnostic capacity. With respect to echo, the Kenya Cardiac Society is doing a great job in the trainings that they have been doing to, as it were, I call it democratizing echocardiography, so that a lot of people have got the capacity, even if not to do, but at least to make sense of what an echo says, because that's what you need. Simplified protocols, there have been various studies done, some in Eldoret. There's been a lot of work done in Rwanda. I think one of our students, under the supervision of Professor Mark Joshi, has just published a paper on point-of-care echocardiography, are quite useful. And then for pro-BNP, maybe I'll have a chat with the Roche guys over coffee. So then we now get into how then can we optimize outcomes in terms of therapy. Now, many of you will recognize the bottom, the base of that triangle there, what we used to call the Holy Trinity or the Three Musketeers, what have you. What was then the three pillars of the treatment of heart failure. And this was based on solid data, on the, countering the neurohumoral or neuroendocrine activation that comes in heart failure. And this was basis of the treatment of heart failure until about 2014. So what has changed since 2014? This is the so-called paradigm study, published in 2014, presented, I think the ESC meeting was in Barcelona that year. I remember that very well. So this is the first time after almost 15 years that there was a new intervention that improved outcomes in heart failure on top of what was then standard therapy. Those of you who can remember, it was sacubitril valsartan compared with enalapril. And you can see all the outcomes there, the primary endpoint, cardiovascular death, hospitalization, and all-cause mortality. So this was a real paradigm shift. They chose a hopeful name, and luckily for them, it got translated into reality. So that was the first advancement. The second advancement was the SGLT2 inhibitors. The first of the SGLT2 inhibitor studies in heart failure was the DAPA-HF, presented, I think, were in Paris in 2019, the last ESC conference before COVID. That again showed that on top of standard therapy, so that is RAS inhibition, MRA, and beta blockade, that the addition of dapagliflozin had these remarkable improvements in outcomes. Again, you can see the various things, the primary outcome, hospitalization, cardiovascular mortality, all-cause mortality. Unquestionably a positive study is empagliflozin. And this is the data from the EMPA-reduced study, which was empagliflozin in heart failure with reduced ejection fraction. So following this is a pooled analysis. The DAPA-HF and EMPA are reduced, so the dapagliflozin and empagliflozin studies. And I don't know whether you can see it well, but there are various endpoints: all-cause mortality, cardiovascular mortality, forest plot. The benefit of SGLT2 inhibition in heart failure was unequivocal. So, people then went and looked at if you use what you would call the current combination, the so-called Fabulous 4, and the forest plot on the left there tells you that whatever the outcome that you're looking at, usually the primary endpoint of most heart failure studies is a combination of hospitalization and cardiovascular death, and that is positive. If you look at cardiovascular death itself, it is positive. If you look at hospitalization alone, it's positive. And when you pool the data, all-cause mortality is actually also positive, which is usually difficult to demonstrate in a single study. And this is an interesting modeling which shows how many years you add to the life of somebody with heart failure when you add these two latter agents. I think the upper one is for somebody who is 55 years, and the estimate is you add 8.3 event-free years to their life. And the lower one is somebody who is 65 years, and you add. So, this then brings us to the so-called Fabulous 4. So in all our patients with heart failure with reduced ejection fraction, unless there's an absolute contraindication, or there is intolerance, and those things happen, they should be on these three: a beta blocker, an MRA, an ANI, and an SGLT2 inhibitor. But the other reason I also put this slide is because I don't have a lot of time, I didn't want to put many other slides, the central 4 that we can do, which then depends on your patient profile. One of the things that we hardly ever do in this environment, despite the fact that we are very conscious of iron deficiency in heart failure, is we never do iron studies. And therefore, we never do supplemental iron. So there is a role there. Another underutilized intervention in our environment, we know, for example, that hydralazine nitrate combination has been shown to be very effective in Africans, even if they were African Americans rather than Africans. We don't do that. Anticoagulation where necessary, and my chair, Professor Jaylan, is one of those guys who likes poking needles into people's groins or arms. So interventions where appropriate. So if now we have, no, before I go there, so I've focused mainly on HFrEF because that is where most of the data is. But we know that we have two studies that have shown that the benefit of SGLT2 inhibitors go beyond reduced ejection fraction and used and preserved ejection fraction. And these are two slides. On the left is dapagliflozin, and on the right is empagliflozin, which basically shows that the benefit of SGLT2 inhibitors in heart failure is there irrespective of ejection fraction. So, the next thing I want to address is initiation of therapy. Most of these studies that I've talked about were done in ambulatory populations. And therefore, initially there was insufficient data both about efficacy and actually tolerance if you initiate them too early. And yet we know that this initial phase, especially after hospitalization, that the initial phase, the number of drugs to the optimum. And you can see that early initiation was useful. How about SGLT2 inhibitors? There was a study called SGLT2 inhibitor called sotagliflozin, which is actually a study which was published late in 2022, that now subjected the hypothesis about the benefit of initiating and up-titrating. I'm told my time is up, okay, 2 minutes, versus rapid up-titration using proBNP. And since Rossi is not too happy with me, let me just go quickly. That was the primary endpoint, all-cause mortality and rehospitalization at 180 days. So early initiation and up-titration is not only possible, and safe, but actually beneficial. I'll skip the second endpoint. So, towards concluding, so what are the issues if we have all these good things? One is, of course, access. And access refers to many things. From a diagnostic point of view, I think we had addressed them, but also the question of cost of drugs. Many of these new molecules are extremely expensive. So that's what we have to work around. Two is polypharmacy. You remember we have 4 critical drugs that your patient has to have. Probably 70% of your patients will need a diuretic. That is number 4. Probably about 30% of your patients will be in atrial fibrillation, so they need an anticoagulant. Probably 15% will be on diabetics, so they need their metformin. Many of them are elderly people with bad joints, so they need something for the pain. So the issue of polypharmacy in heart failure is a real big issue. No clear-cut answers, no easy answers, but one of the things that we need to do when we see people with heart failure is make sure that drugs that are absolutely not needed are excluded. And there is, work towards fixed dose combinations in heart failure. And of course, I've already alluded to comorbidity. So in conclusions, you see I'm a good boy. When I say 2 minutes, this is 2 minutes. So there's clearly a rising burden of heart failure globally. It is associated with considerable morbidity and mortality. There have been major developments in treatment with potential to improve outcomes. However, in the real world, especially in the parts of the world where we live in with resource constraints, there are major challenges in implementation, and I've tried to go through them. And really, all of us have to work, innovatively to mitigate these challenges so that our patients reap the benefit of these advancements. And I think that's it. Thank you.
Thanks. Really nice talk, and really actually quite succinct, so well done for that, Professor Ogola. Our next speaker has been described, in fact, by Professor Ogola as his daughter. Yubreen Mora is going to be talking to us about advances in cardiac imaging, how to look into the heart using different techniques and technologies. Yubreen is now a cardiology fellow in Aberdeen, hopefully coming back to Kenya in the next 3 or 4 months. And as we'll be talking later about BNP, the hormone that is part of the algorithm for making a diagnosis in heart failure. If we're not using drugs, then we may be considering imaging as a better option. Yubreen.
Candid and warm introduction. But yes, imaging is the better option. So I don't need to introduce myself much. Again, I know most of you, and most of you know me. It's lovely to be home. And the heat is quite a lot for Eldoret, but I'm happy to be home. Okay. That's my training center in NHS Grampian in Aberdeen. Very grey. It's called the Grey City or the Granite City. But it's played some movies like the movie Silver City. That's where it was shot. And up there is where my hospital, my ward is on 5th floor and 6th floor, covering the cardiology unit. And we serve NHS Grampian, that's our little helipad, covering the north of the UK. My disclosures is my trip from Aberdeen was covered by Dawa Life Sciences Kenya, but there is no conflict as pertains this presentation. So I'll quickly take us through the history and background so that we just go back to where it all started. And we know cardiac imaging allows us to actually, as I titled my presentation, that it gives us a look and a window to look inside the heart and be able to understand the hemodynamics, the physiology, structural abnormalities, even coronary abnormalities that we now do, myocardial disease, and all the structures involved. The West, and I think Kenya in the near future, we are moving into a multimodal approach involving different modalities with their different strengths to build our case and give our patients optimum care. I'm very aware, and we are all aware about the inequalities that exist for us in this center, in this part of the world, But then slowly we will get there because we have the infrastructure. What we need is the expertise. So that slide generally is emphasizing what I just said, but there are better ways on how to go about it. Looking at Africa and Europe, this paper tried to see how Africa and Europe versus North America are going about cardiovascular imaging practices. But you all would agree with me that the barriers in implementation, particularly for the African continent, is resources. But we will get there when we have the expertise and build our systems correct. Just further emphasis there about, just look at the green. This is data from Africa about the coverage for MRI. Green is private, predominantly private, and I think that's the situation here at home. Hopefully we can have the rest, or was the President's technical advisor on health, that green needs to change so that we have more of this available in the public sectors and our machines are not rotting or just not being used and patients have to pay more out of pocket. But you can see our country, Kenya, down here. Sorry, how does this work? Sorry. Our country there is Kenya. We are not doing much of cardiac imaging on this last graph there, but we are doing more of brain imaging. And I think in the next few years, hopefully upon my return and pulling up together with the Kenya Cardiac Society, we can have more of cardiovascular and heart imaging contributing to better management of our patients. Sorry, my pretty images are in a hurry, and this doesn't seem to work so well. Where are we? Sorry. This technology looks like it's not working for me. It's very sensitive. Sorry. So I've skipped a slide there about the history, and it's not going back, is it? There you go. So the history about all this, we can see right from 1960s to 2020, when now we are doing more fusion imaging from cardiac CT to MRI and echo, fusing these images together, not just to make diagnosis, but to guide structural intervention. And that's where the future is, and that's where we are right now. You'll ask this big fight about what is more important. I think both those organs are important. And now with AI and artificial intelligence, they're fusing together to work and create models that are making diagnostics better and patient follow-up and outcomes getting much better. So echo is what we are all very familiar about. Easy accessibility has been there for so long, been evolving for the past 45 years. Now we have programs that are able to improve image resolution. We are able to get smaller structures being seen better. You're able to do instrumentation by the bedside and get a digital image that is harmonic, automated, and detecting everything with a 3D, 4D capability and speckle tracking, as I'll show you, which makes everything very magical, honestly. So I'll give you an example of a 3D. Those are my pretty images, courtesy of my consultant back in Scotland who gave me some of this. But I'd like you to pay attention. I picked rheumatic valvular disease. It's something that we see a lot in our center. Here in Kenya, sorry, not in our center. We don't see much. We see MR. But in Kenya, MS is quite common. But you can see with 3D reconstruction, you're able to get 3D measurements and a surgical view that you're actually able to measure with precision what is the size of the mitral valve so that you make even more informed decisions and how you should intervene and what should you do for the patient. Is it just maybe a valvotomy, or you need to do a mitral valve replacement? And you can see on the transesophageal echo on the far right, my right, you're seeing that the mixed valve disease is even better visualized now because you're able to see where the jet is directed for you to make the right call for the patient. This is en vogue now, I know, for us here in Kenya. We are doing a bit of strain with a bit of knowledge about it. But you can see this 37-year-old woman who we saw in clinic having come in, develop not postpartum, but peripartum cardiomyopathy is the correct nomenclature, being followed up in a period of 30 days and seeing improvement, and you're able to communicate the right information to the patient, whether they have recovered or they have de novo heart failure, or their potential on reproduction moving forward, or whether they've recovered. This is also very useful in cardio-oncology and also just following up patients, particularly the ones with heart failure with preserved ejection fraction. Just more pretty colors. That's infective endocarditis. You can decide from there that you need surgery or you don't need surgery for the patient, and maybe you're going to explore medical management with antibiotics, and you actually are able to see that the vegetation is around the A2 scallop of the mitral valve, and you can follow up closely and see whether the patient is responding to the medication appropriately. You can see this PFO that has been closed. I really try to make this not so cardiology terminology, but this is a PFO that was closed with that name of a device there. It's a PFO occluder. You're able real time to see the results before you come out from the procedure. And this team, the heart team composed of the structural interventionist and the cardiac imager, together with the interventional cardiac imager, work together to get excellent results. That's an example on how this is fused together to use a multimodal approach, just emphasizing. You have this patient, you've done a stress echo on them, you're seeing apical dyskinesia, and then your angiogram is showing a lesion there. Maybe you think it's TIMI2, TIMI3 maybe, actually TIMI3. But then you're asking, do you need to do anything for this patient? And that extra imaging helps you to make the call and decide on what to do for the patient. Maybe you can do some IVAS or do FFR or IFR, whichever you do, to try to see, do you need to intervene? There is this new and vogue one, very costly. I don't think we'll have it in Kenya soon, but this is a cardiac echocardiography, used a lot with our EP colleagues who are able to use it to guide ablation, particularly for ventricular ablation, guides them on where they need to go and ablate for the patient. And it's once off use. We used it once in my center and you discard it, and one echo, one device, one of the echo, the intracardiac echo, you use it once and it costs more than 7,500 pounds. So maybe not now for us, but this exists too, and it's nice to know. This is just cartoon I'm showing you when we're just doing transducer fuse right there. So you actually know the borders on where you have punctured, on the right atrium into the left atrium, guiding in real time so that the structural interventionist knows what they are doing and they can see the results. And even afterwards, when you pull out, you're able to look at the residual iatrogenic shunt created and whether it's significant, whether you need to do anything about it. Sorry. Just more pictures to just show. This is a mitral valve clip that was being fixed there, which is a transcatheter mitral edge-to-edge repair with the echo guidance intraprocedural. That's a mitral valve replacement using a TAVI valve on mitral position, and you're able to follow up and see what happens. So echo guidance is very critical for structural heart procedures, and it's where the world is now, and I think we can and we have the expertise to move there too. Just a summary that echo is essential. It cannot be overemphasized that it makes us, helps us make decisions, helps with pre-procedural planning, intra-procedural guidance, and post-op follow-up, which we tend to ignore, the post-op follow-up. And now we have a new category of just called structural heart disease interventional images. Cardiology will always have a new subspecialty every time, but you can see that this is where the world is going. So I'll stop there with echo as I quickly rush through a huge topic, but talk about CT, cardiac CT. We've not really established this here in our country. It's where we need to be heading next, but we know from the SCOT heart trial, luckily this was done in Scotland, and so the uptake for cardiac CT is so big there, not just for structural heart, coronaries, but also for CT, TAVI planning and all that, and that's very important. So I'll just summarize about what the SCOT heart trial showed, that characteristic features on CT, which is so available for us here. We have the CT, we have the infrastructure. They can define and be able to guide you as a clinician about high-risk features in patients who are intermediate and low risk who have symptoms of angina. This was a study that involved 4,500 people, and the outcome was really encouraging and now has gained its way into main guideline-directed therapy on how we should manage patients. So that's a summary of what I said, and so I won't dwell on it. I'm running out of time. That's how the pictures look like. You're able to actually describe your lesion, read through it. The computer helps out a lot, and this is the age of artificial intelligence. But then you can see, you're able to see the disease through the LED, and you are able to actually now use CT to guide intervention. We're even doing volume rendered images and functional analysis using CT. Surprise, surprise. It's actually now in use that CT is being used to do functional analysis. The thing is, you just have to get a retrospective instead of just a prospective image acquisition. Aortic stenosis, I know for us it's mitral stenosis, but aortic stenosis is more common than we think in the older population. And CT is king with the aortic valve. Just if there's anything you'll take home today, CT is king with the aortic valve. And just emphasizing about how you do calcium score and deciding, sometimes there are gray areas, do you have severe stenosis or not? And CT is able to tell from the calcium score you get, above 2,000 for men, that, you know, even outcomes have been shown that they are worse the more calcium you have around the aortic valve. And just the same, this study available on Circulation, you can have a look at it by Pawade and colleagues, that really show that the more calcium you have, the more poor outcome cardiovascular-wise you do tend to have in patients with aortic stenosis. Just same thing, but you can see how the fusion here goes. You're able to combine CT. CT is able to assess for ischemia, and you're able to fuse that up with your angiogram and CT-FFR, which is quite costly. We won't be having it in Africa soon, but it's currently being used in the West. Quickly through CMR, I'll be very fast. This is, I think we have an established a service for CMR, I think in a few hospitals around, and I know Eldoret MTRH is yet to launch one. But then it's very good with characterization of myocardium, the pericardium, tries with valvular disease, but not as great as echo. But it's a modality that you use, and now gaining more mainstream acceptance in guiding interventional procedures, even for Jaylan and friends. So what can CMR do? We are doing all those things, from volumes to derived values like regurgitant fraction to define severity of lesions. And now we do other things like ECV, which guides to differentiate some other things like amyloid and Fabry's and myocarditis. Look at this cine image of cardiac MRI with echo on the side. When you see a lesion there and you're like, what's going on? CMR will characterize it for you so well. That hyperintensity is for a thrombus, so that's a thrombus right there. So you see how you fuse this together. And cardiomyopathy is quite rampant. My father, Professor Gorlas, talked about heart failure. And I'm almost at the end of it. Just seeing images again, showing how you characterize the myocardium. You can see the apex is not moving. And the pattern there, it looks very nice, like what is that card called? SPED. And that's for hypertrophic cardiomyopathy. And late gadolinium enhancement tells you which part of the myocardium is dead in the room, and how you make your diagnosis of endomyocardial fibrosis. And tissue characterization, I'll just jump through that, but that's something also that is done.
Explain the outcome. Now, I would like to know what the studies were, because there's so many types of studies. Just say a study was done, because some of the study will have criticism. And I saw you included mortality as one of your outcome. But for most of us current researchers, we don't like using mortality as an outcome. We rather use quality of life, which is more positive. Mortality is completely negative. Now, in the last presentation about the drug SGLT2, you talked about a random trial using that drug in heart failure. But you know, when you do, when you do random clinical trial, you select the patient, particularly. You have some exclusions and inclusions. And one of the exclusions is usually older men with comorbid condition. And yet when you're coming to talk to us how to use this, most of your patients are old people with comorbid condition. How do you get the evidence to use in these people?
I'll take maybe 2 more questions, and then I'll ask the speakers to address them. There's a question. Yes, Dr. Ongai.
Yeah, thank you. Good presentations. To you, Bryn, in terms of myocardial viability between NM and CT in the series at Aberdeen, what is a comparison? And the second one, Elijah, when it comes to resource-constrained settings like KNH, for instance, where it would be a long way to be able to get NM like Khan does, how would you be able to assess that viability clinically to be able to move on ahead and treat?
And maybe one more question. Thank you for that. Dr. Samia.
Yeah, thanks, Chair, and the presentations. I'd just like to make some comment about where we are headed in terms of cardiac imaging. We recognize the fact that many of our centers outside the big cities do not have access to cardiac imaging, and here we are talking of just basic echocardiography. So I know there are a lot of efforts that have been going on for individuals on their own to try and get knowledge and do cardiac imaging. Sometimes the standardization of that imaging has been wanting, and there are efforts both from private players, government sector and so on to improve point of care echo and even the fully fledged echocardiography training, and would like to challenge that those who get these opportunities, please go ahead and enroll in these echo training sessions. My thinking has been that every physician actually should know echocardiography. It's not anymore a reserve of cardiologists. Whether you're the one who is going to be doing the echo on day-to-day, or you just need to understand when you're given a report by a sonographer that your ejection fraction is this, there's wall motion abnormality, or there's a nurse who is in the ward who is managing a patient and has to have some knowledge of echocardiography. So I think this is a challenge that we should all be doing. Then, I don't know, Jelan, my thinking is we're underutilizing cardiac CT and MRI. There's always been the big war, whether it's the radiologist who should be doing this or cardiologist. But a few centers have actually equipment that can do these tests, and nobody is doing them, or the downtime is always there. Remember the other day I was looking for cardiac MRI for one of my patients, and we called all over the city, and either machine was out of order or the technician is not in, and so on. Sometimes embarrassing excuses to give to patients. So I think as a body of physicians and cardiologists for that matter, we need to move out of the comfort zone of echo, move to the CT field, move to the MR field, and take the lead, because the radiologists are not going to be doing this.
Thank you. Maybe I'll respond to your comment, which was directed at me right at the end. Maybe Professor Ogola, you can respond to the questions addressed to you.
Yeah, Joe talked for so long and so long ago that I've even forgotten what he said. Yeah, the problem is, you know, the lung, and Juma is here also, the lung sort of lags behind the heart by about 3 decades. So the question of mortality as an endpoint, the problem is that unlike what, asthma or something, heart disease actually kills. When you have people with grade class 2 to 3, whatever, New York Heart Association heart failure, half of those guys are dead within 5 years. And that is why mortality in cardiovascular trials is an important endpoint. Quality of life is important. And if you read these studies, there's always quality of life addressed, but quality of life of a corpse is 0. So there's no quality of life if you are dead. So that's why we use mortality, because these people die. Yeah, we are talking different languages here. So that's the point I'm trying to make, that there's a hierarchy of things. I want to be alive, and if I'm alive, I want to have a good quality of life, isn't it? If I'm not alive, then the quality of life becomes irrelevant. I mean, it's as simple as that. Then the issue of randomized clinical trial, that is an inherent weakness of randomized clinical trials. It's not just a cardiology issue. But, you know, it's sort of like money. We talk of all the weaknesses of money, but we haven't found a better means of exchange. As per current practice, the best assessment of a new clinical intervention is the randomized clinical trial. What you've said is absolutely true. What then happens after that is that this data is validated in real-life settings using registries, which all these have done. Then the final point you mentioned is that I talked about the trials that didn't give the details of the trials. I would need a whole 1 week seminar to give you all the details of the clinical trials that have just been done in heart failure alone. So when my chair is looking at me and I'm given 15 minutes, obviously I can't give all the details. Dr. Wangai's question. Yeah, your point is valid. I think maybe two things to make. Sometimes, I mean, my pretty daughter here gave us some very pretty pictures. But we have to contextualize. We have to contextualize. The basic imaging in cardiology is echocardiography, and for that matter, transthoracic echocardiography. We then have to be very careful in deciding where these more advanced modalities give incremental benefit that is worth the cost. So that's one part of my answer. The other part of my answer, which sort of talks to what Dr. Samia talked about, is that we actually have the infrastructure. Most level 5 and all level 6 hospitals in this country have got MRI, have got CT scan. So what is needed is upgrading and the software and the interest. I don't think we are suggesting, and I don't think Ubrin was suggesting by any means, that everybody who walks in with heart failure should undergo CMR and all those fancy things, some of which I can't even pronounce. Yeah, so the basic imaging is transthoracic echocardiography, and you can go a long mile with just transthoracic echocardiography, but there are those areas where those advanced imaging certainly make a difference, and it is our job as healthcare workers to try to bring that to our, our population, irrespective of whether they can access private care or not.
Thanks. And maybe Ubrin, you can add a comment to that and also respond to the other question.
I agree with what Professor Gola has mentioned, that there's an algorithm to what test you do at what level. So it's not a blanket sort of requirement that everyone needs to get this. It's what pathology are you looking for. One of my slides that we didn't get to, maybe 3 more before we finished, had a very nice cartoon of how physical examination is supported by the other investigations that could happen. So you have to have a very clear algorithm of what starts first. And in cardiology, it's obviously echo before you move to the next modalities. About your other question about CT and CMR in my training center, it really is dependent on what the indication is, and maybe just reinforces what I'm saying, that it has to be what are you looking for. So if you're looking for myocardial viability, it's the patient who's ahead of you. You choose what they need for them. But most of the time we find ourselves doing more CTs because we have more ischemic disease. We're having a lot of patients have CT, and a lot of patients with myocardial disease, cardiomyopathy, is having more CMRs.
Thank you. That was a really exciting session. Thanks to the speakers. A round of applause for Professor Ogola and Ubrin. And thank you very much. I'm going to hand over to Rosie, who will lead us through the next session.
Thank you, Jaylan, for that excellent moderation. And thank you to the cardiologists for keeping time. So we're going to switch and change gears a little bit and move into the endocrine field. Prof, be gentle. I'm presenting after this. So I have the distinct pleasure of inviting Dr. Rosemary Wanjiru, who's a consultant physician endocrinologist based at the Kenyatta National Hospital, also the current medical director of DMI, and she's going to talk about rational combination therapeutic options for the cardiorenal continuum in type 2 diabetes. Welcome, Daktari.
Good afternoon. Good afternoon. Oh, that's better. So I'm going to talk about the rational combination therapeutic options for the cardiorenal continuum. After speaking after Dr. Baga and Professor Ogola, it will just be a recap since they've already talked about the CKD and the heart failure. So I received an honorarium from Square Pharmaceutical, and they paid for me to come here. And that's a bit of the outline. So just to put us in the mood, and we'll discuss this at the end of the presentation, is you can get a patient who comes, a 60-year-old female teacher who has had diabetes for 12 years, hypertension for 10 years, has had stenting to the LAD 2 years prior, is on gliclazide 120 milligrams once a day, metformin 1 gram twice a day, atorvastatin 40, aspirin 75, amlodipine 5, and telmisartan 80. Physical examination is essentially normal with good blood pressure control. But the key thing is that the lab data, you find the HbA1c is 8%, eGFR is slightly reduced at 60, has an elevated UACR of 50, LDL is acceptable at 1.2 with a TSH of 1.6. So this is the kind of patient we get with the cardiorenal continuum, and you want to find out what else and how are we going to go about it. So when you talk about the cardiorenal continuum, it's where you find a continuous chain of events which are initiated by multiple risk factors, with diabetes being one of the main factors, but you have other things like hypertension, dyslipidemia, metabolic syndrome, obesity. And with that, they usually continuously lead to either end-stage renal disease or heart failure. An intervention anywhere in that continuum would cause, disrupt that pathophysiological process, and with that, we call it providing cardioprotection. So, sorry, I'm told this doesn't have oh yeah, there's a pointer. So with this is just trying to show you the whole cardiorenal continuum where you have your risk factors, and when you're having the risk factors, you're usually asymptomatic. Then after that, you start having a bit of symptoms or signs, and that could be, you could just start by getting microalbuminuria or atherosclerosis forming, and with that, you find you eventually get heart failure or end-stage renal disease. And with this cardiorenal continuum, you want to stop the progression either from risk factors to the development of disease, and stopping at any point will help either to prevent, regress, or retard where we would get mortality and morbidity. So what's the role of type 2 diabetes in this continuum? Is that type 2 diabetes is one of the most relevant risk factor for both heart failure and end-stage renal disease. And when you have type 2 diabetes, it puts you at risk of developing heart failure of about 2.5 times than someone who doesn't have diabetes. And some of the things that lead is that the macroangiopathy will lead you to getting coronary artery disease. You'll get myocardial ischemia, you end up with ischemic cardiomyopathy, and end up with heart failure, mostly reduced ejection fraction. But still, diabetes on itself can cause direct injury to the myocardium, and that can lead to to diabetes cardiomyopathy, and that most of the time the patients present with preserved heart failure that is preserved ejection fraction. Again, when we look at the CKD, you find that most of our patients, as Dr. Baga said, is the second leading cause of end-stage renal disease. And you find that our patients, about 30 to 50% of all patients with diabetes end up developing chronic kidney disease. And it usually starts at a subclinical level, but there are still some patients who might not develop microalbuminuria, but it's always important to look out for microalbuminuria by looking at the urine albumin-creatinine ratio. But although most of the patients will still develop end-stage kidney disease, what usually takes them out is usually cardiovascular disease. So we need to work hand in hand and have a multidisciplinary setup. So this cartoon is a little bit, but it's showing the pathophysiology of how you get the cardiorenal continuum. And with this, you find it can either be coming from the cardiac side or coming from the kidney side. And you find that with that, you have the sympathetic system involved. You also have your atrioneutral ANP and BNP, which will end up blocking the natriuresis. You find perfusion is involved and you have increased venous pressure. Humoral signaling ends up increasing your cytokine secretion. You find that also you have peripheral vasoconstriction and end up releasing angiotensin, and the adrenal gland releases aldosterone that can cause a lot of fibrosis. And now with that, in combination with other systemic factors, either hypertension, they develop amyloidosis or metabolic syndrome, and obesity, which is a big problem, then that activates the sympathetic neurohormonal activation. And with that, the cytokines cause a lot of inflammation. You get endothelial dysfunction, fibrosis, oxidative stress. And with that, finally, you end up with now organ dysfunction, either in your heart or in your kidneys. So this is the point at which you want drugs that are going to stop all that fibrosis and oxidative stress. So when we come to management, we want, again, to give medication that's going to reduce your renin-angiotensin-aldosterone system, and that is how your ACE, your ARBs would come on board. And when you do that, it ends up causing a reduction in your fluid overload, reduction in your oxidative stress, and inflammation and fibrosis. And eventually you will have improved vascular endothelial function and improved cardiorenal hemodynamics. So sorry for this very busy cartoon, but this is now where we come and find that SGLT2 inhibitors, and as much as they were initially used for patients with type 2 diabetes, you find out the cardiologists and the renal physicians are using them maybe more than we are. And the reason why is that we're trying to reduce the fibrosis and reduce the inflammation. And how they do that in heart failure is that you find that the SGLT2s will alter the adipokine regulation. And when that is done, you find that you have suppression of leptin secretion. And eventually you find that you have reduced epicardial fat. And that will improve your cardiac health. You also find that SGLT2 will have an autophagy induction, and with that, again, it will reduce the oxidative stress and inflammation. SGLT2 inhibitors will also improve your cardiac ionic homeostasis, and with that, again, you find it will eventually increase your calcium transport and will improve your cardiac contraction. And then you have improved myocardial energetics. And what happens is that you have increased production of the ketones. And with that, you find that it's a better alternate fuel for the heart and will increase your ATP production and have improved cardiac work efficacy. And now with that, that is why you find SGLT2 inhibitors are very beneficial in the cardiac renal continuum, especially when you have heart failure. Now we've looked at heart failure. What about when we look at the renal? As Dr. Berger said, I won't belabor that point, is that when you have SGLT2 inhibition at the proximal convoluted tubule, you find you will have increased urinary sodium and glucose excretion. And eventually what that does is that it will increase your diuresis, It will also reduce improve the intraglomerular pressure, and with that you end up having benefits in the kidney and retard progression of CKD and retard progression of the patients requiring dialysis, and will improve your eGFR by 2 to 5 millimeters per hour yearly. So the other thing is that the SGLT2 inhibitors with their novel mechanism of action also seem to increase your hematocrit, and because you're also losing a lot of glucose through your urine, you end up having some subtle weight loss. Not found a lot of weight loss clinically, as the books have talked about, but there's some subtle weight loss. So what is the evidence of use of SGLT2 inhibitors? So you'll find the x-axis is looking at the stage in the cardiovascular continuum, and the this is the x-axis is looking at your eGFR, and you can see the DAPA-CKD was done at a much lower eGFR, and you have all the other studies, whether it's the DECLARE, the CANVAS that was using canagliflozin, the EMPA-REG that was using empagliflozin, VATIS that was using etugliflozin, and all the others have shown that there is benefit not only with renal but also with reduction of hospitalization in your heart failure patients. So you can see it's quite useful whether it's renal or heart failure. And then this again is a whole continuum of the cardiorenal, where you have your risk factors, then you have your subclinical disease, and eventually you have your disease, either end stage or cardiovascular. And it shows at the different stages when the studies were done, either the CANVAS or the DECLARE, the VATIS, EMPA-REG, the EMPEROR-R, DAPA-HF, CREDENCE, and DAPA-CKD. And all these studies showed that SGLT2 inhibitors are beneficial. The beauty about SGLT2 inhibitors will not cause hypoglycemia unless you use them with insulin or other medications that would cause hypoglycemia, like sulfonylureas. And the reason is that they block reabsorption of filtered glucose, will only lower plasma glucose by blocking reabsorption of the filtered glucose, so they will not cause hypoglycemia. So after talking about SGLT2 inhibitors, the other agents that are beneficial in the cardiorenal continuum is the GLP-1 agonists. And what they do is that we have GLP-1 agonist receptors in the pancreas, in the kidney, in the heart, and in the gastrointestinal system. And the GLP-1 receptor agonists act by working in the brain by reducing your appetite, and also they increase your insulin production, but only increase your insulin production after there's a glucose load. And they'll also increase satiety. Therefore, they're very useful when we are looking at patients who need to lose weight. So because of working on the GLP-1 receptor agonists, they also affect your cyclic AMP and will increase your ATP, and with that, they have cardiorenal benefits. So with that, there are multiple studies that have been done, and the SGLT2 GLP-1 agonists that have been looked at are the liraglutide, the semaglutide, and dulaglutide. And when we look at the evidence, you find that when evidence favors use of GLP-1 agonists, especially when you have atherosclerotic cardiovascular disease, as shown in this forest plot. I put up this slide to remind us that even if we have these beautiful agents, we should not forget our basic agents. We should not forget our sulfonylureas, our metformin, and all the other basic agents that we usually use for type 2 diabetes. So this slide looks at the patients who had cardiovascular disease, and the second one is the patients who did not have cardiovascular disease. And you can see the GLP-1 agonists really benefited the patients who had history of cardiovascular disease. And even when they looked at the patients who had cardiovascular disease, they still found about 60% of those patients were still on baseline medications that included metformin and sulfonylurea. So in as much as we're looking at a cardiocentric approach, you should also combine it with a glucocentric approach. And that's why the UKPDS showed that every reduction of 1% of your HbA1c helped in reducing your microvascular complications. And when we look at the glucocentric approach, the key thing we're looking at is that you need to get a good metabolic memory to give you a good glycemic and a good legacy effect. And this was found even 1 year later when the HbA1c started increasing. So that's one thing to remember, that in as much as you're looking at your cardiocentric approach, do not forget also looking at your glucose approach. And what is favorable is a patient-centric approach where you combine both. Again, GLP-1 agonists, when they looked at the renal outcomes, they were found to be beneficial. Okay. So what are the combination possibilities when we have our patients who have either CKD or have heart failure? You remember that our patients who have CKD, once the eGFR reaches 60, you should never go above 1 gram of your metformin because of the possibility of getting lactic acidosis. Then when you look at the other agents like your sulfonylureas, you should always try and get them the second generation sulfonylureas. And once the eGFR is at around 30, then you have to be very careful. Once the eGFR is less than 30, then metformin has to be stopped. When we look at the DPP-4 agents, then we have agents that can be given in end-stage renal disease or in CKD without adjusting the medication. That is either linagliptin or teneligliptin. But if you have sitagliptin or vildagliptin, all you need to remember is that you just need to adjust the dosages according to the eGFR. So this was just a cartoon showing other studies that in as much as we're looking at just the glycemic control, we should always look at also bringing down their LDL, looking at inflammation, hypertension, and their elevated triglyceride. So the guidelines, this is a little bit busy, so I'll just talk through it. Is that the guidelines 2024 ADA, and that's what we are using in the Kenyan guidelines, say that once you see your patient, you should individualize your management. And when you're individualizing your management, is that the HbA1c, what fits patient A is not what should fit patient B. Look at the risk factors of hypoglycemia, and if they have multiple comorbidities, if they're also motivated to control their blood sugar. But once you look at them, see if they're at risk of getting atherosclerotic cardiovascular disease, then of course your SGLT2 inhibitors and your GLP-1 agonists should be included in the management. If it's heart failure, definitely it's SGLT2. If it is diabetic kidney disease, then it's either your SGLT2 or your GLP-1 agonist. The key thing to remember is that you should not combine your GLP-1 agonist with a DPP-4 inhibitor because they are incretin, it's the same thing. So I find a couple of prescriptions where you'll find someone is on sitagliptin and they are put on liraglutide. Do not combine because it's the same. But you could combine all the other medications. Pioglitazone can also be used in those patients who are at high risk, but of course if you have renal disease and they are at risk of of fluid overload and the heart failure, then you should avoid the pioglitazone. Basically that's it. So in summary is that throughout the diabetes continuum, you should always agree and achieve individualized A1C targets, meet with your patient and go through those targets every 3 to 6 months because the targets do change. Involve the patient. Then address cardiovascular comorbidities. Do not forget to ask whether they're smoking. Do not forget to address their hypertension. Do not forget to address their dyslipidemia. Do not delay initiation or intensification of treatment, including commencement of insulin. Especially those patients who come with very high sugars, you should start them on insulin so that they can have the glucotoxicity controlled, and thereafter you could consider going back to the orals. Use optimal dosages of evidence-based treatment and combine your treatments. use your SGLT2 inhibitors or GLP-1 agonists if indicated. The problem with GLP-1 agonists is their costs. They're quite expensive, so they are out of reach for most of our patients who are in public hospitals and even in the private hospitals. Include lifestyle intervention. Do not forget lifestyle intervention to include their diet, include their exercise. And do not forget good old metformin. Doesn't mean that metformin and all the other medications have gone out. And there's one thing that we forget to address, and this is prediabetes. And the reason why I put this is that prediabetes is not benign. When prediabetes is there, that's when our microvascular complications begin. So you should start your management with the patients who have prediabetes and go through the whole continuum until they develop the type 2 diabetes. Thank you.
Thank you very much. She was given 30 minutes and she's taken 20, so hey, endocrinologists are doing well. I'll try and keep up with the same momentum and just introduce myself. I'm sure you all know me by now. I'm the one who's been running around the room. I'm Dr. Roslyn Ngugi, and when I'm not busy organizing conferences, I do treat patients as an endocrinologist at the Kenyatta University Teaching Research and Referral Hospital. So coming after speaking, after Prof has spoken and Ubrin and then Dr. Rosemary, there's quite a high bar set, but I'll try and see if I can maintain. Could I have my slides? I'm going to be talking about the role of NT-proBNP. And I know that you had raised questions. He's already smiling. But it's interesting that you started smiling on that and then later on brought someone who was talking about cardiac imaging advances. I'm just thinking in terms of cost. So why are we going to be talking about this? As disclosure, I've been paid by Roche for this, to give this particular talk. But of note is that I have no other disclosures. Why are we talking about type 2 diabetes and the management? It's because I'm sure at any point in time, all of you have been managing these patients with diabetes, and you can see there's a projected increase in the number of cases that we expect it to go up as high as 46%. What, though, is worrying is that the number of deaths that we are expecting to see, most of it is occurring in under 60, not the elderly. So what is causing these patients to die? So you know that most of the patients will present with microvascular complications and macro. So we're talking about your retinopathy, your neuropathy, but that's not what's killing patients. Essentially, what is killing the patients is your macrovascular disease. And what we'll be focusing on today is how are we going to be able to try and reduce the morbidity and mortality of these patients who are having diabetes. And most of the time, problem is our patients are coming late. I really don't need to belabor this slide because Dr. Wanjiru has already talked about the fact that when you have prolonged hyperglycemia with insulin resistance, what you have is production of advanced glycation end products, and as a result, reactive oxygen species and the activation of your sympathetic and your RAS system. What does this happen? It ends up causing heart failure and diabetes. Now, is this a problem for diabetic patients? Perhaps, because you can see on the right here of all the CV complications, heart failure is presenting, most of our type 2 diabetes patients, up to 14% are presenting with heart failure. What we're saying is it's affecting up to 22% of the people with diabetes, and there's an increased risk specifically for your diabetic patients. Prof said that if you have diabetes, you're already having stage A heart failure, right? So you can see on top of that, there's a twofold increased risk of heart failure in men, and in women, it's even worse, it's up to fourfold. Now, what is this contributing to? Further complications and ultimately death, and we find, of course, it dramatically increases with age. What they found surprisingly is with the patients with diabetes, when they compared with their non-diabetic counterparts, there's a 33% greater risk of hospitalization from heart failure if you had diabetes. And when you looked at the length of stay for these patients who had diabetes and heart failure, if you had diabetes, you can see you had an overall longer length of stay and even the amount of time you spend in the ICU. And when we look at the risk of death, it's actually increased by threefold. So we do have a problem. This establishes that. Now, Prof mentioned about the staging of heart failure, so I'm not going to go to that. What I want you to focus on is, when you look at this, you can see diabetes is already stage A heart failure. But I'm wondering how many actually put that in the back of your mind when you see a patient who's newly diagnosed. And the interesting thing is, so we know patients are coming with heart failure, right? Then we went a step further and we did lots of studies, used our SGLT2 inhibitors like Dr. Wanjiru said, and we said, lo and behold, it was actually contributing to reduced hospitalization from heart failure, right? But are we catching these people early enough? That is the question. So how about if we actually able to predict the risk? Who is at risk of heart failure in the patients with type 2 diabetes? You know most of the risk factors, whether you have associated hypertension, obesity, atrial fibrillation. So you know all these risk factors. Then you also know that we have risk assessment profiles like the ESC, ESD. You have the score, which gives you an idea. I'm wondering, by a show of hands, how many actually subject our type 2 diabetes patients to this risk assessment to check for heart failure? Honestly, before this presentation, even I didn't. So what we find is, if we know that there's a problem, why don't we try and see how we can be able to go around this problem? So Prof talked about proBNP and the fact that it's produced by the ventricles, but usually it's produced in response to volume overload and resultant myocardial stretch. Of note is, we usually would ideally use BNP, but what we realized, the NT-proBNP had a longer half-life, so it stays for a longer time, and you'd better use that, of course, for monitoring and also for diagnosis. So what are the problems we have with BNP? And I'm glad Dr. Kalabi is going to give a talk after me. He's going to answer most of your questions. We know with every assay, it can easily be affected by certain variables. So number one is renal clearance. So most of our diabetic patients already have renal disease, diabetic nephropathy. So in that instance, how are we going to be able to interpret? Surprisingly, for obese patients, you find with the lean patients, the BNP is elevated up to 3 times higher than an obese patient for a change. And with atrial fibrillation, it's because your end diastolic pressures are higher, translates to a higher left atrial pressure, you end up with atrial fibrillation. So your NT-proBNP might be spuriously elevated. So in this diabetic patient, do you try and treat that patient assuming that they have heart failure or not? So we look at what they decide to do. I mean, is there evidence that if you actually subjected a patient who's asymptomatic and did an assay on NT-proBNP, there's any value? So we know stage A is when you have the risk, stage B is when you have elevated proBNP above 125, evidence of structural heart disease and increased filling pressure. When they tested the NT-proBNP, you found that it was the earliest molecular detection of heart failure, even that was not even being picked by your risk assessment. So what they actually did was, say, supposing you got about 5,450 patients who had had a recent coronary event. Why would you choose this particular cohort? Because, like Prof said, there's a vulnerable phase where you know these ones are most likely to be at risk of heart failure. Then measured the proBNP at baseline and 6 months later. Now, if you don't have a history of heart failure, then your proBNP levels are not that markedly high. But you can see from 6 months before a patient has presented with heart failure, it was already starting to rise. And of course, by the time you're having heart failure, it's elevated. But for patients who actually had a history of heart failure, the proBNP was elevated right through. So that tells you can actually use it for checking your clinical progress. Now you want to see, what are we doing with our diabetic patients? We keep doing HbA1cs. Is that a way of assessing whether this patient is at risk of heart failure or not? Perhaps not. So what they did is they randomized about 544 patients, and what they did was subject them to assays for proBNP and HbA1c, and wanted to follow them up for 40 months. And you can see that when it came to endpoints, all-cause mortality, cardiac hospitalization, and cardiovascular hospitalization, it was statistically significant for proBNP as opposed to HbA1c. So you'll still do your HbA1c, but it cannot give you a clue whether that patient is at risk of heart failure. And as such, that gives credence to the fact that it would be a good idea to do a proBNP. What about albuminuria? We know most of these patients, by the time you have the diabetic nephropathy, perhaps you'd also have some degree of diabetic cardiomyopathy. So what if you combined it and said head-to-head proBNP against albuminuria, which is what they did, and they followed up these patients for about 33 months. And you'll find with the dark line, the first one, you'll find that if your NT-proBNP was low, it was actually matching with your urine ACR. But the higher your proBNP, the higher your urine ACR, the higher the predictability of that you are going to have heart failure. Now, we don't normally we will probably check for albuminuria, we'll do your HbA1c, but we're not actually assessing or thinking of could this patient be at heart failure. Remember, these patients are dying of or having longer stays in hospital because of heart failure. So how about you compare it head to head against the risk scoring system? So the score is a systemic coronary risk evaluation that patients get, which you can assess for a patient who's had like a myocardial event and see if you can predict the risk of heart failure. This is against the ESC and ESD. The problem with some of these risk assessments is they underestimate, number two, the population they use. So like these risk scoring systems, it's for patients who are aged between 40 to 75. So if your patient is younger or older, begs the question what you're going to do. And then when you go down to the, whether it's African American or other, we always end up on other. And what you'll actually find is when they actually broke down the NT-proBNP, depending on the levels, you found NT-proBNP actually did a better job than the ESC, ESD, which you'll see. So they did head-to-head, like against the ESC, ESD, and also against the scoring. And you can see that with the NT-proBNP, it actually matched whether your proBNP was lower or high. In fact, in some, it actually was a better predictor than your scoring system. And this is also in terms of your endpoints like your CV death and your all-cause death when they looked at the overall cohort, whether you had any CVD as opposed to those without any cardiovascular disease. And you can see in all of them, your NT-proBNP did marginally, of course, much better than in predicting that these patients had heart failure or not. And this is replicated here as well. So when you look at it based on the tertial, that when your NT-proBNP is more than 125, that's the red, NT-proBNP below 50. And you can see that in terms of sensitivity, in terms of the cardiovascular death and all-cause death, NT-proBNP still did marginally better. So what? I mean, we've managed to test and we've seen that perhaps NT-proBNP can actually be useful. So how about if you actually use it in practice? So what they did was do the Pontiac trial. And the Pontiac, they took type 2 diabetic patients, more than 18 years of age, no history of cardiac disease, they had a normal ECG echo, and the proBNP was elevated. So in one cohort where they managed patients at 4 cardiac care units, they followed them up for 2 years, didn't intervene in any way, regardless of what the NT-proBNP was. But you know that the NT-proBNP is elevated in both groups. For the second one, what they did was they up-titrated the RAS blockers and the beta blockers if your NT-proBNP, of course, was elevated. And you can see the relative risk reduction was as high as 65%. So if you actually, most of the time I feel in practice when someone presents in heart failure, you do your NT-proBNP, your echo, you confirm. So you're using it to guide your therapy, but why aren't you using it to help in diagnosis? And this has been shown like in your Canvas trial, when Dr. Wanjiru was talking about the use of canagliflozin, SGLT2 inhibitors, in patients with type 2 diabetes with heart failure, you can see that there was obviously a relative risk reduction in your major adverse cardiovascular events, hospitalization for heart failure, and CV death. So the trials are showing you, when they tested these patients, their proBNP was elevated. When you give drugs, they do better, but how were they noticing that? And that is because you can see canagliflozin reduced the proBNP by 11%, and it was documented by a patient improvement. This was also seen in 14,000 patients who are subjected to the use of dapagliflozin. For those who are sleeping, you better wake up. I'll ask questions. And you can see even with a lower NT-proBNP of 75, it was still useful in monitoring these patients. And what was very interesting is that when you look at the quartiles, this is dependent on the level of your NT-proBNP. So what we find is, of course, the higher the quartile, the higher the risk. My time is not up. The higher the quartile, the higher the risk. And as a result, you find that when you subject them to treatment with DAPA, there's a relative risk reduction that is even higher, the higher your proBNP, and even your absolute risk reduction. So you can use it for monitoring and even for treatment. Similar with your EMPA reduced, you found that they reduced your NT-proBNP by as high as 13%, which was documented in the patients improving as they were given the SGLT2 inhibitors. So the studies have shown it's good for monitoring. I'm telling you it's good for actually screening. But of course, you have to be very specific. You have to pick, because like Prof has said, it's expensive. In a developing country, you have to pick and choose your battles. So they use it to help with diagnosing the heart failure. But I'm telling you that up to a third of our patients are less than 60 and they're dying of heart failure. I am pretty sure if you can be able to actually get the right patients, you'll actually prevent this morbidity. In terms of obesity, I've left this slide because I'll allow Dr. Kalebi to talk about how we are going to interpret the NT-proBNP in such patients. So, how are we going to use it? I've talked so much about what it is, how you can screen, how you can monitor. So, you already know a diabetic patient is at high risk for heart failure. And if you find the NT-proBNP is normal, then you can repeat it at least after a year. On the other hand, if they already have structural disease, and you go ahead and you do your echo, as recommended by KCS, I'm sure, and our seniors, Prof. Ogola, then thereafter, of course, that clinches your diagnosis and you treat, and even they recommend that you monitor with your NT-proBNP every 6 to 12 months. So it's not everyone that you would subject to an NT-proBNP assay, but at the end of the day, if you're actually able to pick the high-risk patients, then I think it's actually something worth thinking about. And with that, I'm done. Thank you very much. I think we'll keep the questions for after Dr. Kalebi's talk, which is only 10 minutes, Prof. I'm seeing the professors leaving. We've had the privilege of having Dr. Ahmed Kalebi come all the way to come and talk to us about the role of point of care NT-proBNP. Prof, your talk was about heart failure. Just listen. And we are talking about how to make it accessible, how we can improve outcomes. Diabetes is only just one of the groups. So I figure if you just give him 10 minutes and he talks about point of care and whether we can apply to our population, it would be great. Plus, he'll answer all your questions. Welcome, Dr. Kalebi.
Hi. Hi, everyone. I'll be very brief because most of the things I wanted to mention have actually been, where's my slide? Where's my presentation? Hi. As I'm waiting for my presentation, actually I was going to start by answering Prof about why are tests very expensive, a test like proBNP, or BNP for that matter in this country. And I'll give you actually an anecdote as an analogy. When I was doing my fellowship in renal pathology in Oxford, we had a patient from Ghana who was a captain, suspected to have malaria. And when the malaria test was ordered, it was going to take basically almost a whole day. And number two, the price of the test was like 200, 300 times more than what we are charged, what we pay here. So I was very shocked. Coming from here, and I'm here in Oxford, I'm like, how can they be so exorbitant when it comes to malaria test? Put that in your mind. Why do you think it's so? Because there, malaria is very rarely ordered. Here, every other Tom, Dick, and Harry will do a malaria. That's a very important factor that I want to mention. But I'll just be talking basically about how do we harness the power of, I really like the theme, person-centered care from promise to practice. There's a lot of promise of these tests that we're talking about, but are we actually applying them? And the reason why I ended up having this discussion, because as most of you guys know, I'd taken a break for 3 years. Recently, I was having a discussion with Roche. We were looking at some of their statistics. The last time I was in a KAP meeting was 5 years ago. A lot has changed, but not much has changed when it comes to pro-BNP testing. I still keep up to date on some of the things that Prof was saying. So then I'm asking myself, if the pro-BNP test being done in the country is this low, it means you guys are not utilizing it. And if you guys are not utilizing it, I'm sorry, I'll be going back to Nairobi after this, so you won't have to. If you guys are not utilizing it, it means patient care is affected. That is the fact. So that's basically what I'm here to talk about. How do I move this? Right. As usual, I'm an evangelist for lab. So I'm here to preach lab. I want more people to do lab, not because I have a lab or I'm going to start a lab, but it's because that is the right thing to do. So we'll be talking about that, and that's basically what I'll be discussing. Oops. I think I'm going the opposite. Okay, right. So the main purpose of my discussion was literally to talk about point of care testing vis-a-vis conventional lab testing for NT-proBNP, its clinical utility, and to give you some perspective on what I think should be done in order to improve patient care. And actually, this is called the Human Rights Framework for Equity in Health. It's actually the subject of my PhD, which I'm doing on COVID testing. But whenever you're looking at testing, the issues of availability, accessibility, affordability, acceptability, and quality. If those elements are not met, then there is inequity. So point of care testing is not just about the place. It's time and place. Somebody needs the test done. They should be able to get it within the time required. And it should be able to make an improvement in terms of clinical outcome and or also economic outcome. And when I talk about power of person-centered testing or person-centered care, a lot of the time I really feel bad for our patients in most of our hospitals. Think about a heart failure patient. They come to the hospital, then they are told to literally walk across several places. They are with their relatives. It is quite problematic for them. That is not person-centered. So the difference between point-of-care testing and conventional testing is simply that with point-of-care testing, you get it done on the spot. For pro-BNP tests, most of them will be between 3 and 5 minutes. If you send your samples to a lab, and I'm not here to advocate against one or the other, I'll tell you the reason why you should choose one or the other. The main thing is, even in the best of hospitals, I mean, let me talk about Aga Khan, very good hospital, Nairobi hospital, but there'll be so many bottlenecks. Your patients will not get their results in less than 3-4 hours because of all those bottlenecks. So those are some of the things you have to consider when you're offering your tests. Why pro-BNP test? Dr. Rosie mentioned about it. It's an amino acid test. Many tests have been done, studies have been done, which have actually gone to show convincingly that it's actually very sensitive and specific for heart failure. But we now know that you can actually use it for screening before even the molecular structural changes, let alone imaging, which is literally way down the line. And Prof. Ogola actually mentioned that and the other speakers. So in general, conventional lab testing for pro-BNP are sent to the lab for testing. Most of the time, if you're lucky, you'll get it in about 2 hours. But think about it. In which scenario do you need point of care testing? I won't belabor that because of time. But when it comes to point of care testing, there's so much advance. I mean, the world has really moved. We have optical tests. Basically, they are all immunoassay tests. Some are optical, others are electrochemical. We can actually get quantification with very good curves, ROC curves, and the rest. And these tests are literally like the rapid test that you're talking about. You are putting it in a gadget, and it can actually read the result. So these are some of the examples of some of the key test platforms that are existing. One of them is this AQT90. A lot of people use it abroad in ICUs. This one actually uses fluorescence. This is from China. It uses fluorescence immunoassay. This is from Abbott. Some of you guys might know the iStat. But actually, the iStat has the best turnaround time in terms of the timing. Although Roche will claim that theirs is the gold standard. Of course, they have data to back that up. But this is the H232. Now, literally, these devices are devices that ideally clinics and all that should have. I was talking about Dr. Wafula Nandu. I was saying, in a hospital like his, he should ideally have both point of care testing, because there'll be patients who will require at the point of care, and have the lab testing for the patients who can actually wait is because of part of another group of tests. There are a lot of studies that have been done to look at point of care testing versus conventional testing. This is one of them, a fairly recent test, a very recent study. Actually, they have gone to show that with the current advances in technology, there is no much difference between these tests in terms of the accuracy and in terms, but the key thing here, I don't know, the pointer is not working for me, but the key thing here is about the issue of acceptability and GP decision making. What is the point of ordering a test in the morning, then the poor mama has to go, and then she has to come the next day, she doesn't even come back. That's why people go to a ganga instead of coming to doctors, because the kind of care we give them is almost like torture. That's the reality, and actually there's a paper to show that. So just remember that it's not only heart failure that can cause elevated proBNP, but with heart failure, the levels are markedly elevated, maybe only comparable to pulmonary hypertension. Dr. Rosie has spoken about all this. So what are the indications for proBNP testing? I'm just summarizing. Diagnosis of heart failure, triage and risk assessment, and this all from even from some of the recent guidelines that came out last year and the year before. Monitoring post-discharge at home, prognostication, prevention of heart failure onset because of the measures that you take, as well as guiding therapy, and Rosie spoke about that. I won't belabor this, but you can literally triage your patients to the extent, and I'm putting it practically, this is clinical practice, not all of you are able to see all your patients. But whether it's your nurse, your MO, your CO, they literally can actually, with this test, they can phone you and tell you, this is the patient we have risk certified, this is a patient who can go home, this is the patient that you need to come and see. Not every patient has to wait for you to put a stethoscope, then send them for an echo. You're actually wasting a lot of time. This test is very, very sensitive, and I'm not talking about for any particular manufacturer. So I think Rosie just basically shared exactly the same. We just got it from different papers in terms of the stepwise approach for screening and diagnosis. The key thing here is stage A and stage B. However good you are as a clinician, you'll never be able to diagnose heart failure in those stages unless you do proBNP testing. And you have those patients. So even if you're a smoker, Professor, or a smoker now, ukitoka hapa enda kafanya proBNP. Seriously, basically that's the message. Yeah, and go do for your patients as well. So the key points in using cardiac biomarkers for heart failure is that these are actually recommended in individuals both who are in stage A, B, but they are particularly useful in stage B because those are the patients who can actually make a difference. And they have a very good negative predictive value, positive predictive value. Now when it comes to specifically for diabetics, they actually have been shown to outperform a lot of other tests. Now there's, in my last few minutes, very, very important. I know I can say this and people tell me, oh, Doctor, you just want to make money, which is a typical thing. Of course, we all want to make money, but we want to help patients. We want to make a difference. There are a lot of studies that have been done looking at economic evaluation of proBNP testing, and that's why the guidelines now have adopted them. This is one of the papers which is quite recent. I think it was 2021. And they compare the clinical assessment alone with proBNP. And it has actually led to decreased hospitalization, decreased admissions, decreased better outcome, and cost saving. There is another, I think there's another one as well, looking at cost saving of proBNP, that if you look at point of care and lab, both of them will lead to reduced need for hospitalization, for echo and the rest. But when you're actually looking at point of care, it leads to better, higher cost saving, because what you are doing, you are able to attend to the patient at that particular point. I think that's my second last slide. This is another paper which just came out recently as well. And in this case, they're actually looking at ambulatory care, and they're actually saying that in most studies, the use of BNP, by the way, I forgot to mention this. So the reason why you use NT-proBNP, because as Rosie said, it's a more stable compound. Yeah, it has a longer half-life, but even in vitro, it's more stable. BNP has its use. It's mainly used for patients who are in ICU, acute heart failure, because it has a short half-life, you can be able to monitor them quickly. But if you're talking about patients that you need to monitor over a period, then NT-proBNP is a better test, but you can actually have both of them. So this is my last slide, at least from a practical perspective. What do you choose between point of care versus lab tests? The lab, and I thought about this analogy actually yesterday, and I said, what are you going to choose to carry your, what can you carry? Soil in your garden. You have to go dispose soil in your garden if you're constructing. Are you going to use a wheelbarrow? Are you going to use a tuk-tuk? Are you going to use a pickup? Are you going to use a canter? All of them can apply. It literally depends on the circumstances. If Dr. Koech has his clinic for cardiology at MTRH on the first floor. And other patients are coming from, the main lab is on the other side. You don't want a scenario whereby you're going to use a pickup to be dragging samples from, I'm using the analogy of samples. The patients have to move from one place. You can actually use your pickup, but sorry, your mkokoteni, not wheelbarrow, sorry. You'll use your wheelbarrow, because the wheelbarrow will have its advantage. But you can imagine the wheelbarrow, if you're going to use wheelbarrow many trips, then it's not economical. Then you'll go from higher volume. In some cases, you might actually need both in a hospital. So one does not exclude the other. So what I'll basically just say is the choice of all that depends on economy of scale. And the last point I'll make is that the more tests people do in an environment, the lower the price. If actually all of you guys start testing patients properly in your different environments, you'll actually be able to bring the cost of these things down, because you can actually talk to people like Roche and tell them, with this volume, the prices must go down. But it's a chicken and egg situation. And once it's a guideline and people agree, you are home and dry. So I think I'll stop there. Thank you very much. And we can have the discussion.
Good, so we have our 3 speakers on stage. So if you have any question, just raise your hand and I'll come to where you are. Dr. Rosemary, NT-proBNP for, oh good. Dr. Kalebi and Dr. Roslyn as well.
Since Rosie made me stay, so let me let me have my word. Mine are probably more comments than questions. So first for Dr. Kalebi, the answer you've given me is something that Roche has given me many times. And it's something I find conceptually disturbing, that a manufacturer is telling you, if you want me to lower my price, buy my product. You put it in an impossible situation. And I know that for many things, there are, access programs and all that. And while clearly there is the benefit of the economy of numbers, when the price differential is by a factor of 10 or something, then I'm not sure it can be, entirely explained on that. To Rosie, the question of role of BNP or pro-BNP, especially in diabetes, it clearly has a role. And I remember I was in this meeting where I was invited by my friends from Roche here. There were some of the big names in BNP, Caroline Lam and Professor Januzzi and all that. And it was a difficult thing. And if you remember, the ESD has been hesitant to recommend routine use of pro-BNP. The ADA has done it. So the way I look at it, again, talking to what we talked about imaging, I think is contextualizing and seeing which patient is it going to make a difference in what I do. If I have my type 2 diabetes patient who is hypertensive, almost all of them are hypertensive, has got an elevated UACR. If I do a pro-BNP, is it going to change what I do for that patient? Because I'm costing the patient money. So while it clearly has its utility, I think it has got to be contextualized. For Rosemary, maybe just to say, since you are supposed to talk about the cardiometabolic renal spectrum, you mainly, this is with respect to GLP-1 agonists, you mainly address their use in the diabetes context. Just to highlight the fact that we now, just like happened for SGLT2 inhibitors, there is evidence of their utility beyond diabetes. Last year at the ESC, we had a presentation of a study of use of, I think it was semaglutide, in obese patients with HFpEF without diabetes, or rather with or without diabetes. And recently at the AHA conference, another paper was presented, I forget the name of the trial, where there was clear reduction in cardiovascular events in obese patients, whether they were diabetic or not, again with the use of semaglutide. So just like SGLT2, the spectrum is going beyond patients with diabetes. I think I've gotten back my pound of flesh.
Prof, just a comment. I mean, this is an advice to all of you in the room. The reality is you can actually get the prices of tests down. It's all about putting your foot down when you're negotiating with the suppliers. There are very many nowadays. And you actually give them a target price. And they have to take a chance with you. I mean, 2009 when I started Lancet, I remember I was discussing then with Roche. That's why I have a close relationship with them then. And I could not even give 10% of the volumes commitment. But because of the discussions I had with the VP of Roche then, he said, look, I told them one thing. There is no I'll give an example of immunohistochemistry for breast cancer. So I told them, there's no difference between breast cancer patients in Kenya and breast cancer patients in South Africa. Why is it that they're putting their prices so high? And actually what eventually led is that they gave me the same price that I was getting in South Africa. And the reality is with time, we even outgrew South Africa in terms of per capita volume for some of the tests. The reality is, I think if you guys can actually say, look, I'll give an example of MTRH. I was with Florence this morning, the lab manager at MTRH. And actually asked about procalcitonin, pro-BNP, and she was saying the tests are not being ordered. And she doesn't know whether it's because of the price, but she told me the pediatricians are doing a lot of procalcitonin because they've realized the value. It actually saves hospital stay and the rest. So there are a lot of discussions to have, but what I'll say for you guys as a body of physicians, if you guys make it, what can I say? You have all these other guidelines, but in general, that these are your guidelines. No physician will be doing less than 5 to 10 P a day in his clinic and the patients he's seeing. That will lead to volumes. And then you can actually demand and say, we want this price and you should be able to get it. Conceptually, it is possible. I've done it. We'll do it again, and we can always do it. And then you pull in terms of scale. Roche, there's no reason why Roche cannot even not give you the H232 for free. They can actually be able to give you for free, and you literally pay per test, not even buying the reagents. You actually pay per test as you use it, because other countries have done that.
Thank you very much. I routinely do BNP, and it's made a dramatic impact on the care of our patients.
You should publish that data. That's good.
Completely dramatic. The outcomes of the patients are evidence-based. I'm able to intensify treatment when required. I'm able to avoid giving unnecessary medication because of making the diagnosis the way I should. There are patients who cannot afford both echo and ECG, and I'm able to use the BNP to make a decision whether they are doing well or not. I strongly encourage the use of that test, and it's affordable. It's actually affordable. There are vendors in town who are selling equipment that are at an affordable rate. From my own practice, a few thousand people, I have no doubt that it makes a difference.
Me. Yeah. Thank you very much. Jonathan Wala, Dr. Kalebi, how are you?
Hey, Sefa Wala. He was my roommate.
Roommate since undergraduate. Yeah. So Kalebi, thanks a lot for your good presentation. You have tried to extricate yourself from this problem of cost. You haven't done a good job on it, I must say, because you have tried to recommend that we order tests without there being a reason for it.
No, I didn't say that. No.
Okay, thank you very much. Just a clarification. So Afunanato has mentioned the fact that he's using it more and more, and therefore maybe if you use it more and more, the cost will come down more. My question will be twofold. The first one is that pharmacokinetics of that pro-BNP in renal failure patients. Yes. We always have a problem with pulmonary edema patients, whether it's just mere fluid overload or heart failure, whether it makes a difference, whether these are the medicines we can add. There's a bit of therapeutic nihilism in kidney disease. Do you think it will have a role for differentiating such patients? And then my second point would be for the point of care testing, it's dry chemistry, is it?
You can call it dry chemistry, but the reality is that the technology is the same.
So if you use it as dry chemistry, do you think it will save the iatrogenic anemia you get in ICU patients whom we bleed every morning for labs? Thanks a lot.
That's a good point, yeah. You know the answer. But let me start with the first question, which was the renal patients. Actually, renal patients, obesity patients, we know that their values can be spuriously different, elevated. Now, the reality is in those patients, and that's why I think several people have mentioned, you don't interpret these tests in isolation. You interpret them in the clinical patient, but the negative predictive value of the lower of the negative cutoff is the most important. That one, you can sleep easy. That if somebody is negative, they can go away for a whole year and come back, repeat after a year. That's basically what all these studies have done by physicians are saying, not even by the lab people. But on the higher side, now you have to triage and go to the next level of the pathway in terms of testing. What the simplistic way I look at it is for patients that you are monitoring in stage B, you take a test now, you repeat it after 6 months, there's a debate 6 months or 1 year. If after 6 months the figures are actually going higher, well, that's a patient who's a candidate for heart failure, you want to start managing them and prevent them from going to stage C. That's basically the most important utility. And that's what basically the Americans are now saying very strongly. Yeah. And in terms of, so the technology is not so different. The only difference is the other one, you're having reagents in tubes and liquid form, while this other one is said to be dry, but the technology is exactly the same. It's all immunoassay test. It's just how you measure it, yes. The dry chemistry has the advantage, by the way, that you can actually use plasma, you can use whole blood, you can use serum. Yeah, that's the advantage of most of these, what you call dry chemistry tests. But they are all different technologies.
Okay, so I think in the interest of time, we're going to end the session there. So let's have the photograph for our 3 speakers. And let's give them a big round of applause. So thank you so much, Dr. Rosalind Ngugi, Dr. Ahmed Kalebi, for making time to come with us. And it's an excellent collaboration, pathology and internal medicine, and Dr. Rosemary Wanjiru as well. Thank you so much. So now we'll be shifting gears now into 2 parallel sessions. That's going to be oncology and respiratory. So Dr. Juma Buika, you'll be heading the respiratory session. We have 3 talks lined up, and that's highlighting on management of COPD in low resource settings by Dr. Abdul Aziz Mahmood. Then we have a talk by Dr. Andrew O'War, tuberculosis, post-TB complications, airway disease, cavitation, and aspergillosis. Then we have pulmonary rehab in resource poor settings by Professor Lamek Diero. So that will be in Sosian. That's, we go 1 floor up. Sosian is the corridor opposite the farmer's restaurant where we have all our meals. Then here, oncology remains here. Oncology being chaired by Dr. Sarah Awino and Dr. Njiru Evangeline. Yes.
So in the interest of time, this is going to run for about 50 minutes, and then you'll be able to break for tea by 4:45 for about half an hour. Then you come back at 5:30 for another breakout session. The first place you'll have endocrinology here, and then the research presentations will be at Sosian A and B. Please keep time so that you can come back and we continue with the rest of the program. Again, we apologize for the delay in time, but thank you for your patience. So if we can have the chair of the session come on up.
So Dr. Njiru and Dr. Sarah, we know where